Welcome to the Deep Dive. Today we're tackling a really crucial area in medicine, how we manage patients around the time they have vascular surgery.
Yeah, it's that critical window before, during, and immediately after the operation itself.
Exactly. Think of this as your insider's guide. Our roadmap comes from a cornerstone text, Rutherford's Vascular Surgery, specifically chapters 24 through 37. They're all about this perioperative period.
That's right. These chapters are incredibly comprehensive, covering, pretty much everything surrounding the operation.
It might sound technical, and, well, some of it is. But our goal here is to pull out the most vital insights.
Mm-hmm. To give you a really solid understanding of what matters most for keeping patients safe and getting them the best possible outcomes, we want to make it clear, accessible, no matter your background.
Absolutely. Whether you're a seasoned pro needing a refresher, maybe you're studying this stuff, or you're just curious about high-stakes medical care, you're in the right place.
So the mission, if you like.
Yeah, our mission today is to break down the key things we think about when managing these patients. Before surgery, during the procedure itself, and then that really important time right afterwards.
We'll cover risk assessment, anesthesia choices,
Right.
what happens minute by minute in the OR, and what it takes to get recovery started smoothly.
Okay, let's dig in. Where do we start? Preoperatively.
Yeah, let's start before the surgery, the preoperative assessment. Rutherford's really hammers home that a detailed history and a physical exam are, well, non-negotiable for elective vascular surgery.
Right, it's not just ticking boxes. It's where you start building that individual risk profile for the patient.
Exactly. And it's not just the conversation and exam. Standard blood work is fundamental.
Okay, so what are we looking for there?
Well, a complete blood count, or CBC, that flags things like infection, tells us about their red blood cells, any underlying blood disorders.
Makes sense.
Then electrolytes, potassium, calcium, magnesium, these are absolutely critical for heart function. Any imbalances, you really want to correct those before surgery to cut down cardiac risk.
Okay. And kidney function. That often comes up with vascular patients, right?
Yeah, it does. So checking creatinine and eGFR, that's estimated glomerular filtration rate, is vital. It gives us their baseline kidney function,
Got it.
plus glucose levels. And for diabetics, their HbA1c gives a longer-term view of blood sugar control.
And clotting.
Definitely. Coagulation tests like APTT, PT, INR. These tell us if there are existing clotting issues and, crucially, help us plan for patients already on blood thinners.
Right. That needs a specific strategy. Rutherford's also mentions the ASA classification.
Yes, the American Society of Anesthesiologists scale. It's a good shorthand for assessing a patient's overall health status before they even get near the OR, a quick risk snapshot.
Okay. Moving on to the heart. Cardiac evaluation sounds like a major focus.
Huge focus. The risk of a heart attack, myocardial infarction after vascular surgery isn't trivial. It's a big driver of mortality. So the ACACA guidelines, which Rutherford's covers, give us a framework.
And how does that framework work?
It looks at two main things: the patient's functional status, basically, what they can do day to day, and the stress level of the planned surgery itself.
Functional status. Can you break that down a bit, like in practical terms?
Sure. We often use METs, metabolic equivalents. Sitting still is 1 MET. Walking up a couple of flights of stairs, maybe light housework, that's around 4 METs. Running might be 10 or more.
Okay.
And the guidelines also group vascular procedures by their risk of major adverse cardiac events in the first month. Asymptomatic carotid surgery is low risk. Open aortic surgery is high risk. Things like leg bypasses or clot removal fall somewhere in between, often intermediate or high.
Right. So if someone can, say, handle 4 METs or more, maybe they jog lightly or do heavy yard work.
Yeah, if they can manage 4 to 10 METs and they've had a normal stress test recently or maybe a heart procedure in the last few years, they likely don't need a bunch more cardiac testing before many vascular surgeries.
But if they get breathless just walking around the house less than 4 METs,
Then yeah, especially for those intermediate or high-risk surgeries, further cardiac workup is probably needed.
okay. Now, Rutherford's also mentions beta blockers before surgery. That's been debated a bit, hasn't it?
It really has. It's controversial. The thinking used to be that starting them might protect the heart, but the evidence has been, well, conflicting. Some big studies didn't show a clear benefit and even flagged potential downsides like stroke or severe low heart rate.
So what's the current approach?
Generally, if a patient is already on beta blockers long term, you continue them, starting them fresh just before surgery. Maybe consider it for higher risk patients with several cardiac risk factors, but definitely not on the day of surgery itself. Caution is the word.
Interesting. So consistency with their usual meds seems key. What about other medications?
Mostly, yes, continue their established meds. The big exceptions are usually ACE inhibitors and ARBs, common blood pressure drugs.
Why stop those?
There's a risk they can cause troublesome low blood pressure during anesthesia, and the benefit of continuing them right through surgery isn't clear.
Okay. But some meds you do want them on.
Definitely. High-intensity statins, the cholesterol drugs. Rutherford's highlights good evidence they reduce cardiovascular problems and even limb loss risk. So ideally, start those beforehand and keep them going.
What if a patient has known heart blockages? Do they need bypass or stents before the vascular surgery?
That's a really important question. Rutherford's points to the ARB trial, which looked at exactly this.
And what did it find?
It found that routinely doing coronary revascularization stents or bypass just because someone needs major vascular surgery doesn't necessarily improve outcomes, either short-term or long-term.
So you wouldn't do it just as a preventative measure for the vascular op?
Generally, no. Those heart procedures are usually reserved for patients who meet the standard criteria for them anyway, like severe left main disease, irrespective of the planned vascular surgery.
Right. Treat the heart condition if it needs treating on its own merits. Now, blood pressure during surgery always seems like a balancing act.
It is. There's no single magic number. Too high is bad, too low is bad. The general aim is often to keep their pressure within, say, 10–20% of their usual baseline.
So individual targets.
Pretty much. Maybe a MAP, mean arterial pressure, of at least 60 if their baseline is low, and keep the systolic pressure under 160 if their baseline is high. Continue their usual meds, except, as we said, hold the ACEs and ARBs typically.
And you mentioned electrolytes earlier.
Yes, potassium specifically. Got to make sure their potassium level is optimized before surgery. Abnormal potassium is a recipe for cardiac instability.
Okay, really important checks. Let's switch to blood sugar glucose management. How big a deal is that?
It's a very big deal. High blood sugar, hyperglycemia, is common in these patients, and Rutherford cites numerous studies linking it to worse outcomes.
Like what kind of outcomes?
Increased risk of death, MI, stroke, kidney failure, wound complications, infections, limb loss, longer hospital stays, you name it.
Wow. And is that just for known diabetics?
Interestingly, no. Even patients without known diabetes who develop high blood sugar around surgery seem to have worse outcomes.
So the goal must be to keep blood sugar really tight, really low then.
Logically, you'd think so. But here's the kicker. It's more nuanced. While high sugar is clearly bad, large studies haven't definitively proven that aggressively forcing it down with, say, intensive insulin drips right around surgery actually improves those major outcomes.
Really?
Yeah, and aggressive treatment carries its own risk, causing hypoglycaemia, dangerously low blood sugar. So the optimal target range perioperatively. Still debated. Reasonable control is key, but super tight control is controversial.
That is surprising. Okay, what about adrenal function? Steroids.
Right, for patients on long-term steroids like prednisone, there's a risk their own adrenal glands won't respond properly to the stress of surgery. This can lead to adrenal crisis.
You need to screen for that.
Absolutely. Need to ask about steroid use or any condition causing adrenal insufficiency. Rutherford's generally recommends giving stress dose steroids extra doses around surgery for patients on, say, 5 milligrams of prednisone or more daily, or equivalent.
But not for everyone on steroids.
No, generally not for lower doses or short-term use. The risk is mainly with chronic, higher dose therapy.
Got it. Okay, let's talk blood, anemia, and coagulation assessment.
Anemia, low red cell count before surgery, is a definite red flag. Rutherford's makes it clear it increases risks postoperatively, morbidity, and mortality.
So ideally, you treat it beforehand.
If possible, yes. Identify the cause: iron deficiency, inflammation, nutritional issues, and treat it. Transfusions aren't a first resort.
Why not just transfuse?
Transfusions have risks too: reactions, fluid overload, immune effects, infections, though where now. They're generally reserved for symptomatic patients, active bleeding with severe anemia, or those with very poor physiological reserve.
So a restrictive approach.
Generally, yes. Often considering transfusion if hemoglobin drops below 7 GDL, maybe 8 GDL in patients with known heart disease who are symptomatic. For elective cases, things like IV iron, erythropoietin, B12, folate might be used preoperatively.
Okay. And preventing clots. VTE prophylaxis and managing anticoagulants. Sounds tricky.
It is a balancing act. Rutherford stresses assessing both the thromboembolic risk and the bleeding risk for each patient and procedure.
How do you manage warfarin, for example?
Traditionally, we'd stop warfarin and maybe bridge with shorter-acting heparin injections, but the thinking is evolving. Some recent data suggests continuing warfarin might be safe, even preferable for certain vascular procedures, avoiding the bridging risks. It's individualized.
What about the newer ones, the DOACs?
Direct oral anticoagulants. Less specific data in vascular surgery compared to warfarin, as Rutherford's notes. General approach is stopping them a set number of days before surgery depends on the specific drug and procedure's bleeding risk, and restarting afterwards when bleeding risk is low.
Are there reversal agents for those?
Yes, thankfully, specific reversal agents are available for some DOACs now, which is a big safety net if major bleeding occurs.
And preventing clots generally, like DVTs or PEs?
Standard VTE prophylaxis guidelines, like those from ASH or NACAS, usually recommend chemical prophylaxis, low molecular weight heparin, or unfractionated heparin, often combined with mechanical methods like compression stockings for many vascular surgery patients.
Okay. Infection is always a concern with surgery. Preoperative considerations.
Huge concern. Rutherford's is clear. Any active infection beforehand significantly ups the risk of surgical site infection, SSI, and other complications.
Where might infections be hiding?
Common spots are UTIs, lung infections, maybe an infected ischemic foot or toe, or even infection around existing grafts or stents.
So if you find one,
Ideally, delay elective surgery. Treat the infection with targeted antibiotics based on cultures if possible.
what about preventative antibiotics for the surgery itself?
Prophylactic antibiotics are standard for most vascular procedures, usually given within an hour before incision and stopped soon after closure for clean cases.
What drugs typically?
Cefazolin or cefuroxime are common first choices. Alternatives like clindamycin or vancomycin are used for allergies, or if there's a high risk of MRSA, methicillin-resistant Staph aureus.
Ah, MRSA.
Yeah.
Is screening for that common before vascular surgery?
Rutherford's mentions it's a growing problem. Screening and decolonization protocols have shown some promise in other surgical fields, like cardiac or ortho, but the routine use in vascular surgery is still kind of debated, less established.
All right, nutrition. How important is that preoperatively?
Very important and often overlooked. Rutherford's points out that malnutrition is surprisingly common in vascular patients and significantly increases risks.
All kinds of risks.
Impaired wound healing, higher infection rates, lung complications, longer hospital stays, increased morbidity, even mortality. These patients are often older, maybe less mobile, poorer diets, plus other conditions like diabetes or kidney disease compound it.
How do you assess nutrition?
A good history is key weight loss, appetite changes, functional decline, GI symptoms, and the physical exam looking at body habitus, muscle wasting, signs of deficiencies.
Any blood tests that help?
Serum albumin is a key one. Rutherford's notes it reflects chronic protein status, and lower levels are consistently linked with worse outcomes after major vascular surgery.
Okay. One last preoperative topic. Frailty. What's that about?
Frailty is basically a measure of reduced physiologic reserve, someone's overall vulnerability to stressors like surgery. It's a better predictor of outcomes than age alone sometimes.
How do you measure it?
Rutherford's mentions a modified frailty index, using data often collected routinely, like in the NSQIP database. Higher frailty scores correlate strongly with increased complications and death after vascular surgery.
Can you do anything about frailty before surgery?
Prehabilitation exercise, nutritional support has shown benefit in some surgical populations, but Rutherford's notes the evidence specifically for vascular patients is still developing, less clear-cut.
Okay, that's a massive amount to consider before the patient even gets to the OR. Let's move inside the operating room now. Intraoperative management. Anesthesia first.
Right, and as Rutherford says, it's all about tailoring the anesthetic to the patient and the procedure. Their ASA status, comorbidities, it all plays in.
What are the main types?
You've got local or regional numbing, just a specific area with drugs like lidocaine or bupivacaine. Then moderate sedation, the patient's relaxed, maybe sleepy but conscious. Often uses drugs like midazolam, fentanyl. Reversal agents are available if needed.
What about spinal or epidurals?
That's neuraxial anesthesia. Can provide excellent pain control and can sometimes be used safely even with anticoagulants, following very specific guidelines about timing.
And then the big one, general anesthesia.
Exactly. Complete loss of consciousness requires airway protection, usually mechanical ventilation. The drugs used can cause vasodilation, drop blood pressure, affect heart function, and interfere with temperature regulation.
Special considerations for kidney patients.
Absolutely. Careful fluid management, watching electrolytes closely, managing their baseline anemia, all critical for patients with chronic renal failure under anesthesia.
Okay, they're asleep.
Yeah.
How do we monitor their hemodynamics, blood pressure, heart function?
Several tools, as Rutherford's outlines. Central venous catheters measure CVP, central venous pressure. Once thought key for fluid status, we now know CVP is affected by many things, so its value for that specific purpose is debated.
What about arterial lines?
Peripheral arterial lines, usually in the wrist, radial, or sometimes groin, femoral, give continuous beat-to-beat blood pressure, essential, also allows easy blood sampling. And remember, the MAP, mean arterial pressure, is often a better indicator of perfusion than systolic or diastolic alone.
I've heard of Swan-Ganz catheters.
Pulmonary artery catheters, or PACs, they give more detailed info cardiac output, pulmonary pressures, but their use has declined a lot. Major trials didn't show they improve survival, maybe even increase risks, reserved for very complex cases now, if at all.
What about TT, transesophageal echo?
TE uses ultrasound via the esophagus, gives great real-time views of the heart and aorta. Very useful during cardiac and major aortic surgery to assess function, look for problems. But again, like PACS, proving it improves overall outcomes has been difficult.
Any newer monitoring techniques?
Yes, Rutherford's mentions newer, less invasive devices emerging, things like ClearSight or FlowMedR, aiming to provide hemodynamic data or even limb perfusion info without invasive catheters. Still evolving technology.
Okay, so we're monitoring closely. What are the key goals for maintaining homeostasis internal balance during the operation?
Temperature's huge, hypothermia getting cold is bad. Rutherford stresses it worsens coagulopathy, messes with platelet function, increases surgical site infection risk.
How do you prevent that?
Simple things often work. Pre-warming the patient, using forced air warming blankets, warming IV fluids, sometimes warming the inhaled gases. Keep the OR reasonably warm.
And blood sugar, we talked about that preoperatively.
Still critical intraoperatively. That link between hyperglycemia and surgical site infection is strong. So, aiming for reasonable glucose control, avoiding major highs is important. But again, remember the nice sugar trial showing risks with too tight control, namely hypoglycemia.
Right, that balance again. What about anticoagulation during vascular procedures?
Essential when arteries are clamped, unfractionated heparin is the standard, usually given just before clamping, either a fixed dose or weight-based.
Does it last the whole surgery?
It has a relatively short half-life, so for longer procedures, repeat doses might be needed. Sometimes monitored with ACT activated clotting time, though ACT readings can be variable.
Can you reverse heparin if needed? Like if there's bleeding?
Yes, protamine sulfate reverses heparin, but protamine itself has potential side effects, like allergic reactions or blood pressure drops, so it's used carefully.
What if someone can't get heparin? Like heparin-induced thrombocytopenia, HIT.
There are alternatives like argatrobin or bivalirudin for HIT patients. Reversing those is harder. They'll rely more on non-specific agents.
What about patients already on antiplatelet drugs, like aspirin or Plavix? Especially if they have stents.
That's a major challenge. Stopping dual antiplatelet therapy, DAPT, too soon dramatically increases the risk of stent thrombosis, a heart attack. Current guidelines generally favor continuing aspirin through surgery if possible. Managing DAPT requires careful discussion between cardiology, surgery, and anesthesia.
Rutherford also mentions intraoperative thrombolysis.
Briefly, yes. Using clot-busting drugs during surgery, sometimes as an adjunct to mechanically removing a clot in acute limb ischemia, but systematic data on optimal dosing and its overall effectiveness versus risk, especially the risk of brain hemorrhage, is limited. It's used selectively.
Okay. Managing blood loss and transfusion during surgery. How does the body cope initially?
The body tries to compensate for blood loss, heart beats faster, stroke volume increases, veins constrict. But these mechanisms have limits, especially in vascular patients who often have underlying heart disease.
When do you decide to transfuse?
It's based on several factors. Are they showing symptoms of poor oxygen delivery? How low is their hemoglobin? What's their overall cardiovascular status? Rutherford discusses transfusion triggers, often using HB thresholds like 7 or 8 GDL, but clinical context is key.
What are the risks of transfusion?
Allogeneic transfusion blood from a donor carries risks. Immunologic reactions range from mild fevers to severe hemolytic reactions or transfusion-related acute lung injury, TRALI. Also, transfusion-associated circulatory overload, TACO, and infectious risks, though much lower now with screening bacterial contamination, especially platelets, viruses like HIV, hepatitis B, C, others.
So how do you minimize needing donor blood?
Multiple strategies Rutherford mentions. Meticulous surgical hemostasis is paramount. Limiting blood draws for labs, maintaining normothermia, as we discussed, promptly managing any coagulopathy, using careful fluid resuscitation. And sometimes autologous techniques like cell salvage, collecting and reinfusing the patient's own lost blood, acute normovolemic hemodilution, or preoperative autologous donation, though these have limitations and aren't always practical.
Okay, surgery's done. Patient's heading to the ICU or step-down unit. Postoperative management begins. Who needs the ICU?
Rutherford's lists predictors: older age, underlying COPD or heart failure, significant intraoperative blood loss or long surgery, complex procedures like juxtarenal aortic repair, kidney failure needing dialysis, ongoing need for ventilation. Basically, higher risk patients needing closer monitoring.
And that monitoring continues.
Absolutely critical. Beyond just BP and heart rate, we're looking at organ perfusion indicators. CVP, maybe pulmonary capillary wedge pressure, PCWP, or cardiac output, CO in select cases, urine output, lactate levels, tissue oxygenation or CO2 monitoring, mixed venous oxygen saturation. The whole picture.
Still using central lines and arterial lines?
Often, yes. Central lines for CVP, remembering its limitations for volume status and reliable IV access. Need to watch for malposition. Arterial lines for continuous BP and sampling still need careful zeroing and calibration. Radial versus femoral sites have different complication profiles.
PACE or echo post-op.
PACs rarely used routinely post-op, maybe only in the most complex hemodynamic instability. Bedside echo, however, can be very useful non-invasively to assess cardiac function if there are concerns. Rutherford also mentions intra-abdominal pressure monitoring after major abdominal vascular surgery, and those newer non-invasive monitors might play a role too.
Okay, let's talk common postoperative cardiovascular issues. High blood pressure seems frequent.
Very common post-op causes. Rutherford lists many: residual anesthesia effects, hypoxia, high CO2, fluid overload, being cold, pain, anxiety, rebound hypertension if meds were held.
I worry about it.
Risks include bleeding at surgical sites with suture lines, increased strain on the heart leading to ischemia or failure.
What are the targets?
Generally aim to keep systolic BP within maybe 20 millimolars of their preoperative baseline, or MAP within 20%. We often use short-acting IV meds initially, beta blockers like labetalol or esmolol, calcium channel blockers like nicardipine, sometimes ACE inhibitors like enalaprilat, or vasodilators like nitroglycerin or nitroprusside for emergencies.
What about the opposite, hypotension?
Also common. Causes include anesthesia effects lingering, hypovolemia, low volume from blood loss or inadequate fluids, cardiac dysfunction, pump failure, or vasodilation from sepsis or other causes.
How do you manage that?
First, address the cause. Often start with fluid boluses if hypovolemia is suspected. If fluids aren't enough, vasoactive drugs, vasopressors are needed. Phenylephrine or dopamine might be used peripherally short-term. Norepinephrine or vasopressin are common choices via central line.
What if it's the heart pump itself?
If it's cardiogenic dysfunction, you might need inotropes drugs that increase contractility, like epinephrine or dobutamine. Maybe even mechanical support devices in severe cases. And always evaluate for underlying myocardial ischemia.
Arrhythmias, irregular heartbeats. More common in these patients.
Yes, especially those with pre-existing structural heart disease. Post-op triggers are common: hypoxia, high CO2, electrolyte imbalances, potassium, magnesium, ischemia, pain, stress.
Goals of treatment.
Maintain hemodynamic stability, control the heart rate, and ideally restore normal sinus rhythm.
What about fast rhythms, tachyarrhythmias?
Depends on the type. Supraventricular ones like sinus tach, atrial fibrillation, AF. Flutter often focus on rate control first with beta blockers, calcium channel blockers, sometimes digoxin or amiodarone. Cardioversion if they're unstable. Ventricular tachycardia, VT, managed triggers. Follow ACLS protocols if unstable. Pulseless VT is cardiac arrest. Use antiarrhythmics like amiodarone or lidocaine for stable VT. A specific type, Torsades de Pointe, needs AV magnesium.
Atrial fibrillation seems particularly common.
Extremely common post-op. Management involves rate control, sometimes rhythm control, cardioversion, but need to consider clot risk first, and always assessing the need for anticoagulation to prevent stroke.
And slow rhythms, bradyarrhythmias.
Often due to high vagal tone medications or sometimes ischemia, usually only treated if they're causing symptoms or hemodynamic compromise, low BP, dizziness. Atropine is first line, then maybe dopamine or epinephrine infusion or temporary pacing if needed.
Okay, the big one. Postoperative myocardial infarction, MI.
The most common major cardiac complication and cause of death after vascular surgery, according to Rutherford's, detection can be tricky.
Why tricky?
Classic chest pain might be absent or masked by surgical pain or sedation. So you rely heavily on ECG changes and cardiac biomarkers, CKMB, and especially troponin I or T.
What if troponin is up but they have no symptoms?
Rutherford's emphasizes that even asymptomatic troponin elevation after vascular surgery is significant and predicts worse outcomes. It shouldn't be ignored.
How do you manage a post-op MI if it's a STEMI?
STEMI ST elevation MI is an emergency. Specific ECG changes plus elevated biomarkers. Treatment involves oxygen, maybe nitrates for afterload reduction, antiplatelet drugs, anticoagulation, and urgent reperfusion.
Reperfusion after surgery. Isn't that risky?
Yes, bleeding risk is high. PCI, angioplasty, and stenting is generally preferred over fibrinolytic clot-busting drugs post-operatively. SAID surgery might be needed for failed PCI or complex anatomy. Beta blocker should be started unless contraindicated.
What about non-STEMI?
And STEMI is elevated biomarkers without the classic ST elevation, often due to supply-demand mismatch in the heart. May present subtly, maybe with shortness of breath or heart failure symptoms. ECG might show T-wave inversions or ST depression. Mortality risk scales with the degree of troponin elevation. Management is more medical initially, with risk stratification guiding decisions about invasive strategies.
Okay. Shifting from the heart to the lungs. Respiratory management post-op.
Critically important. Need to assess and optimize breathing. Risk factors for pulmonary complications are well known. Age, COPD, heart failure, smoking history, obesity, type of surgery, especially upper abdominal or thoracic, long anesthesia time.
How do you reduce those risks?
Rutherford's mentioned several strategies. Preoperative smoking cessation is huge, optimizing cachidasma with bronchodilators or steroids, encouraging lung expansion maneuvers, post-op deep breathing, incentive spirometry, good pain control so they can breathe deeply, and early mobilization getting patients up and moving.
What if they need mechanical ventilation?
Need clear indications for ongoing ventilation. Different modes can be used: pressure control, volume control. Key thing, especially in ARDS, acute respiratory distress syndrome, is using lung protective strategies. Low tidal volumes, allowing slightly higher CO2, permissive hypercapnia, to avoid ventilator-induced lung injury.
How do you get them off the ventilator? Weaning.
It's a process. Assess readiness daily, often called a wake up and breathe approach. If they meet criteria, try a spontaneous breathing trial, SBT, where they breathe with minimal support. If they pass the SBT and meet other criteria, stable, good mental status, can protect airway, manage secretions, good cough, then consider extubation. Failed extubation is risky, increases complications.
What about tracheostomy?
If prolonged ventilation, say 7-14 days is expected, tracheostomy might be considered. Rutherford's notes benefits like patient comfort, better oral hygiene, easier secretion management, potential for speech. It has its own complications too. Early tracheostomy might facilitate weaning and shorten ICU stay in some patient groups.
Post-operative bleeding, always a worry after vascular surgery. How do you spot it?
Urgent evaluation needed if fluid requirements are unexpectedly high or escalating. Signs of hypovolemia, we discussed. Tachycardia, hypotension, low CVP, low urine output, cool extremities.
What if you suspect surgical bleeding?
If the patient is unstable, escalating pressure needs, you assume it's surgical bleeding until proven otherwise. Rapid assessment, maybe point of care labs like ISTAT, activate the OR team, get blood products ready. Imaging might be used for more stable patients.
Could it be coagulopathy instead?
Absolutely. Need immediate checks. APTT, INR, platelet count, fibrinogen. Rutherford's often includes tables summarizing causes: residual heparin, warfarin effect, low platelets, platelet dysfunction from meds or bypass, hypothermia, dilution, fibrinolysis, DIC, and their specific treatments. Protamine, vitamin KPCC, platelets, FFP, cryoprecipitate, tranexamic acid, etc.
Fluid and electrolyte management post-op.
Right.
Any key principles?
Needs to be individualized, as Rutherford's emphasizes. Calculate maintenance needs, but titrate fluid administration to physiologic endpoints: urine output, if kidneys are okay, hemodynamics, perfusion markers. Avoid fluid overload that's increasingly recognized as harmful. Balanced salt solutions, like lactated ringers or plasmolite, are often preferred for large volume resuscitation over plain saline.
Colloids versus crystalloids.
The debate continues, but large trials generally haven't shown a survival benefit for expensive colloids like albumin compared to crystalloids for routine resuscitation.
Renal failure post-op.
Biggest predictor is pre-existing kidney disease. Rutherford notes that drugs previously thought to be renal protective, like low-dose dopamine or phenoldiprem, haven't panned out in trials. Management is supportive, careful fluid balance, avoiding kidney toxic drugs, managing electrolytes, using diuretics judiciously, and dialysis if needed.
Any other key post-op considerations Rutherford covers?
Gastrointestinal ischemia, lack of blood flow to the gut, is a potential complication, especially after aortic surgery. Need to watch for abdominal pain, distension, bloody diarrhea. Nutrition is important. Start enteral feeding, tube feeds early if possible, within 24-48 hours in the ICU. If the gut isn't working, consider parenteral nutrition, IV feeding, after about 7 days.
Pain management.
Crucial. Poorly controlled pain increases stress response, hinders mobility and breathing. Neuraxial techniques, epidurals, can be great. Reduce opioid needs, may improve gut function, potentially lower clot lung risks, facilitate early movement, but need careful coordination with anticoagulation timing.
Bridging anticoagulation post-op.
Generally reserved for very high-risk patients like mechanical mitral valve, older aortic valves who need to restart warfarin. Involves stopping warfarin pre-op, using heparin post-op until the INR is therapeutic again from restarting warfarin.
Yeah.
It's a careful balance of bleeding versus clotting risk.
And finally, sedation and delirium.
Delirium is incredibly common in ICU patients, especially elderly vascular patients. Rutherford highlights risk factors: age, baseline cognitive impairment, psychoactive drugs, ventilation, pain, sleep deprivation. It presents in different ways: hyperactive, hypoactive, mixed. Diagnosed using tools like the CAM ICU, it's a strong predictor of longer stays and mortality, so prevention and management are key.
Wow. That was an incredibly detailed journey through the perioperative period for vascular surgery patients, all grounded in Rutherford's chapters 24 to 37. It really underscores how complex this is.
It absolutely is. I think the main takeaway really is just how vital meticulous assessment, tailored interventions, and vigilant continuous monitoring are across every single phase: pre-op, intra-op, post-op.
Yeah, it's not one size fits all. It's about the individual patient, their specific risks, their other health issues, and the exact surgery they're having.
Precisely. You have to consider everything together.
This deep dive really lays a solid foundation for understanding this critical field. For you listening, maybe reflect on what stood out most. Perhaps the nuances of cardiac risk assessment, or the challenges of managing anticoagulation, or maybe the importance of recognizing delirium.
Yeah, and hopefully it provides context for why certain things are done. We encourage you to explore further if something sparked your interest.
And as we finish, maybe a final thought. This area of medicine is constantly evolving. Research continues, techniques improve, our understanding deepens.
True. It's all part of that continuous pursuit of making surgery safer and improving outcomes for these often very complex patients. A fascinating and vital field.